So to just sum up the summary of setting the ventilation, you start with control or assist control ventilation. It can be, limit can be pressure or volume. If it is a pressure limit, it becomes pressure mode. If it is a volume limit, it is a volume mode. Trigger, you have to set in. Normally, there can be pressure trigger or there can be flow trigger. Nowadays, flow trigger is preferred. So if it is a flow, around 3 liter of the flow drop should be okay, or -2. If it is pressure trigger, setting of 2 should be okay if it's a new generation machine. So this trigger will work when patient will try to breathe in. If patient will not try to breathe in, it will not trigger. The most important concept is flow rate I ratio TI. There are 3 things you can get in different kind of ventilator. This is important because, as I told you, for me the most important thing is IE ratio. See, like this patient, he has a RDS, I want I ratio 1:1. So suppose I select a rate of 20, that means I have a respiratory time of 3 seconds. So out of that 1.5 second I want inspiratory time, 1.5 second I want expiratory time. So if my ventilator gives to set up I ratio, then I can directly set the I ratio. Then machine will automatically set the TI time and accordingly flow rate. But some ventilator machine will not allow you to set TI. Some will ask you to set the I ratio TI. So when you have to set the TI in control mode, to achieve 1:1 ratio, you will set 1.5 second. This is also easy if you can control. So suppose you have to giving a rate of 30, then you have 2 seconds of ventilation, 1 second is inspiration, 1 second expiration. Problem happen, we have to select the flow rate to select the I ratio. You have to realize that when you will increase the flow, it will decrease the flow rate is inversely proportional to inspiratory time. So if you increase the flow, TI will decrease. So in a patient of COPD and asthma, you increase the flow to decrease the TI and achieve I ratio of 1:4 to 1:5 or 1:6. But in ARDS patient, you decrease the flow to increase the time, as flow rate is inversely proportional to inspiratory time. That means in a patient of ARDS, you will reduce the flow rate, and when you will reduce the flow rate, your machine will tell you the IE ratio. You reduce or inspiratory time. So you reduce it to achieve a target of 1.5 second time. If you have set the TI of 20 rate of 20, or if you are monitoring I ratio, it should be achieved I ratio of 1:1. As I said, the limit which will be selected, again, limit can be either flow limit or inspiratory time. So if you are using volume, you are using pressure mode, you have to select the inspiratory time, and when that inspiratory time will be achieved, the ventilator will go to the ventilator will ventilate till that time, and then it will go to expiratory phase. But if you are using flow mode, then ventilator will achieve its flow rate. Once achieving the flow rate, it will start reducing its flow rate, and when the flow rate will be reduced to 30%, 25 or 30% of its peak flow rate, then it will cycle to the expiratory. The importance of understanding the cycle is, if it is a control mode ventilation, it is either inspiratory time or flow rate which put the patient on expiratory phase. Now, here you can have some problem if a patient start breathing spontaneously, and if you have fixed the flow rate or fixed the inspiratory time. So patient will not allow a patient to cycle if inspiratory time is fixed or flow rate is fixed. So this is the condition where if you find a lot of cycling problem, then you have to change the mode or put the patient on a spontaneous ventilation, so patient can decide a cycle also to avoid patient ventilator asynchrony. To begin with, we start a PEEP of 5. Most of the time nowadays cycle comes as the inbuilt characteristic of in modern ventilator, where you do not have to know, but some of the older ventilator you have to fix the cycle. Peep is one thing which you have to decide as per compliance. If to begin with lung compliance are low, you do not give more than 5 or 6 or 8 Peep. If patient is non-compliant, if compliance is low, then you give high Peep. If non-compliant, like normal lung or COPD lung, where lungs are not compliant, then you do not give very high PEEP or up to 8 PEEP you give, otherwise causes lung injury. In ARDS also, we recognize two kind of lung. A very compliant soft lung initially, where PEEP is low initially, and later on when lungs get fibrosed in COVID patient, then you have to use higher PEEP. So to select the PEEP, you need to little bit understand about the compliance of the ventilator patient, which is really a long-term training in critical care, and accordingly PEEP is decided. But what you need to understand about the PEEP is it improves oxygenation, it improves ventilation, it improves comfort, but simultaneously it can distend the alveoli and can cause lung injury and harm to the patient. So selecting PEEP is very, very important. As I told you, FiO2 we select is 100%.